here's my thought is, what if I just use this phone for you to hear? Okay. Right. Well, I would mute it. I would mute it here because he could hear you on the IFB. But yeah, I could. Yeah. Let me try that. Just plug it straight in and see if it works that way. Hang on a second. Okay. Can you hear me still? Yeah. Yeah. Okay, well, let's do it this way then, because yeah, I don't know what's going on with that JK box, but as soon as I plug it in, I start getting ground problem with it. Yeah. Okay, sounds good. Sounds good. Hello. Hey. Yeah, I hear you fine. Yeah, you little low. Let me. I've got a booster. Let me go grab that and put that in line. I'll be right back. All right, can you hear me now? Are you still there? There you go. Yeah, I'm going to plug this other thing in and just give me a chance here to see if it still sounds good. Hang on. Talk to me now. Can you talk to me now? You still there? Okay. Yeah, I guess I can't use that. All right. All right, well. Yeah, if you could turn the volume up any more. Yeah, that's better. Yeah, we're all good, I think. Yes. Yeah, I'm looking right at you in the prompter monitor. Oh, okay. So you want to see him on the monitors? That okay? Let me just go move that. Yeah, I can put it, yeah. Yeah, I'll do that. Okay, I just put some paper over so you can't see it. Does that work for you? Let me sit down here and so you can see kind of what it's going to look like. Okay, all right, let me, hang on one second. Okay. Um, yeah, let me see what I can do. Oh, you've already got a copy? Okay. If you want to grab a seat here, you can put it on, oh, here if you want. Sit on this table if you want.
Oh, okay. Get the glasses out of the way for a minute.
Okay, you should be able to hear him talking to you.
Not yet. There, you're coming in. Yeah. Not real loud, but I hear. Maybe a little more on the volume.
Turn that air off so sound better.
Boy, I'm having a hard time hearing. Talking?
The air will be off in a minute, it should be better.
Yeah. Okay, I'm hearing, yeah, okay. Yeah, that's what okay. I hear you, yeah. Yeah, I do. Ye- Okay. Because he really, I'd like to dial him up like 2 clicks if that's possible. Because I have to really concentrate. I'm going to be looking like I'm not hearing on camera.
I think once the air conditioning comes off, it'll be easier for him to, if you can ask him to turn it up on his end.
So he's got,
He's got
okay,
a lot of control there.
okay.
Just gonna take a minute or so for this air conditioning cycle off. There it is.
Oh, pretty good, Neil. How are you? Oh, happy to. Can you guys turn your sound up just a bit? I'm going to look like I'm straining to hear you if we don't get that up. And our audience are surgeons, right? A little bit louder. I mean, it's no danger of ear damage. I appreciate. Yeah, I mean, I hear you, but it's. I can't tell. There's no difference when he's doing things. It's all the same sound. But if you can talk up, then I can. Because that's what we ran into last time I did it with Sarah. I was having a hard time hearing.
I think it's pulled out a ear a little bit there. Is that better now?
That's better, yeah.
Yeah, it pulled out a year a little bit.
Okay, if we hold there, I think we'll be okay. Yeah. Okay, all right. Are you hearing Dr. Love talking? No? Are you recording? They're asking, are you ready to go? Are you recording?
Okay, I am recording everywhere.
He's now recording everywhere, he said.
Camera and audio.
Camera and audio. Oh. Mm-hmm. Oh yeah, no. I mean, the big three: the HER2 targets, the ER targets, and then the neither group, basically. Yeah. Oh yeah. No, there's no question. I mean, that's how we approach them. That's the first thing we do clinically is put them into those three bins. You know, there's obviously within those there's all kinds of heterogeneity that I think we're going to have to keep working through to really keep moving things forward. But yeah, no, I think that would be very consistent with I think how medical oncologists now are thinking. Mm-hmm. You know, I have a hard time speaking to that. My surgeons in my academic center get it. But that is the power of the multidisciplinary conferences. You know, I think the divide now really is that early decision of neoadjuvant. Is neoadjuvant better because of the phenotype of this cancer than adjuvant, even if things technically we could do surgery? Should we do neoadjuvant first because of the type of cancer? I mean, I think that's the real challenge that's probably, and I think from what I've been told is out there in the community as I've been talking with people about, you know, the implications of the Catherine study with TDM1, is it going to be practice changing? How quickly will it be adopted? Because I think it is going to require, in some places, a modification of practice patterns. So I think there is an educational challenge that we're facing with this evolution, I guess. I guess the one that we spend a lot of time actually about talk in our discussions are in our hormone receptor positive patients, particularly those who have are grade 3, where the estrogen receptor staining intensity is not as great. Do we do Oncotype to help us decide if we do neoadjuvant chemotherapy or not? We're spending a lot more time on that in our conferences. I think the other areas of the triple negative and HER2 positive, there's enough consensus that those aren't really the confounders. I mean, there's still always the question that is being addressed in trials about, in patients who have really good responses, pathologic complete responses, role of radiation therapy, if your sentinel node is positive, a little bit positive, and there's all those granular kind of questions. But I think the place where we have the most struggle are these hormone receptor positive patients and the role of neoadjuvant versus adjuvant chemotherapy. Sure. Yeah, I mean, NSABP, as you know, is now merged with GOG, RTOG into NRG. And the combined groups have continued with the winter meeting and the summer meeting that we have a part of. We also have the expanded, I guess, to a degree, the NSABP Foundation portfolio, and honestly, we are still working on the best model to get together. Should that be an extra symposium attached to the NRG meeting? Should that be a separate meeting? We have been trying different things, and really, honestly, Neil, don't have a firm decision yet, is the honest answer. Well, Norm has retired from his clinical practice. He was director of the cancer center there at the Allegheny General Hospital for many years, and he's now retired. So he is working now, in a sense, full-time at the NSABP operations office there in Pittsburgh, and his intent is to really focus on the foundation, organizing the foundation in terms of are we going to meet regularly, extent of the portfolio, strategic plans. He felt like he needed to spend time on that. He also has announced that while he's going to start out in this next grant cycle as one of the PIs for NRG, it's his intent to not be part of the next application 6 years from now, so we'll be looking at transition within the NSABP component of NRG as well. But he's still very, very active and intends to remain that way in the foundation efforts, both on the breast and the colorectal side. Well, most of the NSABP Foundation has existed, quite some time, actually. I think as far back as the B31 days, and so there, over the years of trials and things, that we have been able to accumulate some money that's within the foundation. But that continues to be a challenge, is, raising money. How do you raise money? How much of the foundation money do you spend on your research? These are a lot of the important things that we're wrestling with, as are the other groups, Alliance, SWOG, Precog. It's all the same kind of challenges, because clearly, the scope of the NCI breast cancer trials is not what it was, and we're needing to, and we feel like in order for us to, meet our mission, our purpose of doing, practice-changing breast cancer, colorectal, early phase studies, we need to be able to collaborate readily with pharma as well as with the NCI. And Catherine was an example of a collaboration outside, successful example of that type of a trial. We're currently working with the German Breast Group on a neoadjuvant atezolizumab study. Yeah, for our 50th anniversary of NSABP down in Florida somewhere, I can't remember which town it was, but we did that. We had a meeting that you guys sort of helped us with ahead of our main meeting. That was I remember it was the 50th anniversary meeting. Yeah, we should talk about doing it again sometime. Okay. Okay. Yes, I have them here. Sure. Yeah. They back in summer of 2015, I saw a 46-year-old premenopausal woman who had presented for diagnostic mammography after she noted thickening in her right breast. She had very dense breast parenchyma, but the ultrasound was able to see about a 2-centimeter mass. Biopsy of the mass showed a grade 2 invasive lobular that had ER staining intensity of 2+ in 30% of cells, and PR intensity of 3+ in about 30% of cells. The Ki-67 was also quite elevated at 35%, but the tumor was HER2 negative. Her breast MRI, though, showed, which isn't surprising with lobular, a larger area of enhancement that measured 4 by 3.2 centimeters. So we kind of thought that with lobular histology, this was probably more extensive than was suggested by the mammogram ultrasound. Yes, yeah, and this was some years ago. Yeah, this was the local assay that we have in our hospital. And so, I don't find they're the thing that I rely on the least. If they are consistent, I guess I sort of believe it. If they're inconsistent, it's the thing that I look more for additional confirmation on. And the case with her is she was initially, there was some interest in breast conservation. She had the lobular histology, dense parenchyma. So we decided in her, and with that Ki-67 kind of thinking, well, we're probably going to be giving chemotherapy, even though there's that whole question about, well, does lobular respond to chemotherapy? So we had sent the tumor for an oncotype and were a bit surprised that it came back quite low at 10. The other thing that we did in her was she did have enough family history that we did genetic testing, and it turned out she had a deleterious CHEK2 mutation. So she opted to go ahead and have bilateral mastectomies and not have the breast conservation. But at the point where, when we were first getting things going, there was a question of neoadjuvant, so that's why we had the Oncotype score done pre-op. I've lost you. It's moved out of my ear. Hang on. It popped out of my ear. It's got a little. I have to. Okay, go ahead. Yeah. Correct. Mm-hmm. It's in that family. It's not a real high relative risk indicator. It's the risk of breast cancer is like double. Colorectal cancer is up a bit. Those are the two main tumor types, so it's not a real strong one. But in her with the lobular histology, there was always the question about breast conservation versus bilateral with the lobular histology, and then when we got the CHEK2 deleterious mutation, it crystallized the treatment, and she wanted to go ahead and have the surgery. At surgery, we found, which is not unusual with lobular, we found more in the breast than what the imaging had suggested. She actually had 5 discrete foci of invasive lobular carcinoma, the largest measured 4.5 centimeters. She had a sentinel node procedure done, and actually the yield was quite high, which is gratifying. You're happy to see that with lobular. There were actually 8 sentinel nodes identified, and we did check them all with IHC. We tend to do that with lobular, and they were all negative for cytokeratin on IHC as well as H&E. Well, for lobulars, where we have a worrisome lobular in the breast, we go ahead and do that. It's not at all routinely. It's very much specific to lobular, and where you're wanting to make that decision about chemotherapy, yes or no. Because sometimes, sometimes if your pathologist does IHC stains, they'll go from node negative to actually seeing cancer in several nodes, which would clearly alter our treatment approach generally. So the thing that was interesting with her was, okay, so we have negative nodes, but we do have this, very large T2 tumor, other areas of tumor. We had kind of, ER-PR that were not real strong, a high Ki-67, yet this oncotype that seemed to be discordant with our IHC results. And what I did in this case, and I still do from time to time, is I will get a kind of a referee opinion, more or less. So we sent the breast tumor itself off for mammoprint, and that returned low risk, and the blueprint was consistent with luminal A cancer, so it reinforced the findings of the oncotype. So we kind of had consistency with our genomic panel markers. It was some discordance with our IHC. So we basically treated her based on the genomic marker concordance. We started her on Zoladex, and then shortly thereafter began letrozole. She had intended to undergo oophorectomy within the next 6 months because of the CHEK2 mutation. So we just bridged her with the Zoladex until she had that done, and then placed her on the letrozole. And I, personally, I guess I'm a believer in the ABCSG18 data. I tend to use the denosumab every 6 months supporting AI therapy in my patients that I'm treating with AIs from the start. So that's why she's on the denosumab. Yeah, I mean, from the, of course, the Taylor-X data gave us very, I think, important, encouraging information in the low-risk group first, the patients who had scores of 10 or less. You know, that we reported on that first, the 5-year distant recurrence-free rate was, 98, 99%, and so you really do with just endocrine therapy alone. So we generally believe that the benefit of chemotherapy really is primarily in reducing those events in that first 5-year period. So you're going to see impact or loss of benefit from omitting chemotherapy in the first 5 years. So we had that information initially. A few years later, Joe reported on the randomized portion that really took the 10 up to 15. We saw that patients basically scores of 15 or less actually did very, very well. We had further follow-up on that low risk cohort. So it really, I think, for the recurrence score, it really did show us clearly that in everybody with scores of 15 or less, there just was no need to think about chemotherapy. Prognostically, they had a very favorable prognosis, and with endocrine therapy alone, they would have that very low risk reduced further, and they would get the benefit of the chemoprevention, the other things that are important endpoints in patients with ER-positive breast cancer. The interesting thing is that it did, the study was designed, of course, statistically to look at everybody together, all ages together, all the way up to the score of 25. And in that, it really showed you did not lose benefit from chemotherapy when you combined everybody, looked at the group as a whole, all the way up to a score of 25. The interesting thing, though, was when you started looking at subsets, it really looked like that was true for the majority of the patients, 2/3 of patients who were 50 and above or postmenopausal. But in the younger women under 50, you started to have evidence there that you were probably losing benefit from chemotherapy as you moved 16 to 20 and definitely 21 up to 25. The thing we don't know is that benefit that's being lost due to loss of the cytotoxic effect of the chemotherapy, or is it the ovarian suppression that chemotherapy induces, and could you get a similar benefit by being aggressive with your endocrine therapy? That's going to remain an unanswered question, because I don't think realistically we could ever launch a randomized trial to give us the answer. I think without question, some of that lost benefit of chemotherapy is the loss of ovarian suppression, and that's supported by the long-term data from SOFT and TEXT. You see that ovarian suppression really does have an absolute substantial effect. So I think it's one of these situations where we're never going to have the perfect trial, the perfect data set to give us all the answers, but when you look at it in aggregate, I think those patients in that intermediate risk group, the real important thing for them is being aggressive with their endocrine therapy. The chemotherapy is a discussion point, but I think it helps, if you have a patient certainly a younger patient. The thing that I like about the Taylor-X study, the Oncotype recurrence score, I feel like it gives us much more nuanced information, because I like the recurrence score range. I like the fact that the prognosis varies according to range, the intensity of your endocrine therapy you can probably modulate depending on your score. Someone with an intermediate score, you probably want to give AIs. You may want to go longer to 10 years. Lower scores, TAM's probably all you need. So for me as a medical oncologist, there's a lot of granularity in the Taylor-X data, particularly coupled with SOFT and TEXT, that it's why I prefer that as a genomic profile to the MammaPrint. Clearly, the MammaPrint provides information. It can tell you the main thing that we do, the Oncotype 4, is to give us the chemotherapy yes/no question, and the MammaPrint gives that same question. So they both provide valuable information, but beyond that, what I would like to know more when I'm counseling my patient, when I'm making long-term treatment decisions, when I'm encouraging them to hang in there with side effects, I like the granularity of the data that we have from the TAILOR-X, the longer follow-up. And I think the report that Joe gave at the recent ASCO that incorporated the clinical risk alongside the genomic risk really is very, very nice information that I think the medical oncologist can take into the clinic. Now, for a surgeon, I don't know that detail is so important, but I think it is important in terms of what their day-to-day work, but I think it's important for them to understand that there might be important information their medical oncologist can use from a recurrence score that might not be there with MammaPrint if they're getting involved with deciding who orders a test. Because a lot of times, if the surgeon has ordered the test, then I, as a medical oncologist, I can't do repeat tests. In this particular case, we got permission to do it because I could argue about the discordance, but it took a lot of work to get the approval to get that MammaPrint done. Yeah, I mean, I think the thing about, particularly at SOFT, I think was really critical because it gave us it isolated that ovarian suppression information relative to tamoxifen, and because clearly from the designs of the studies, the U.S. breast oncologists really wanted to see that. We weren't convinced ovarian suppression was something that should be offered routinely. The Europeans doing text had pretty much felt that, yeah, that should be done, and the question is, what drug should we partner with it? So they were coming at this issue from, a little bit different approaches, but I think together they give great information because of the consistency across the trial. And then you could combine the ovarian suppression with tamoxifen and AI across the studies and really get very large, robust data sets. So they are useful. But for me, I think the information that was so interesting from SOFT was that patients actually, the improvement going from tamoxifen to ovarian suppression AI, patients got almost that far with the ovarian suppression tamoxifen. They did do a bit better if you took their estrogen levels down further, but when you look at the curves, when you look at the data sets, the bulk of the improvement really took place when you added the ovarian suppression to the tamoxifen, and then the AI took it up a bit further. And I think that's useful for clinical practice, and because the higher the risk, the more willing you are to at least say, well, let's see how you tolerate an aromatase inhibitor. Because you have a higher risk ER-positive breast cancer, I might be more aggressive with it. But, as you move down the risk scale, and this gets back to the recurrence score, because we know those patients with scores 10 or less, they're going to do fine really whether you give them TAM or an AI. On the lower end of the intermediate, the data kind of looks the same way. It's as you get higher where you need to think more aggressively about using ovarian suppression and an aromatase inhibitor. Well, this thing just pops out of my ear. It will not stay. I'm sorry, Neil. It just keeps popping out. Maybe I'm moving my head too much.
Let's see if I can help you here.
It's like it's got a little tension on it. It's popping out. And tape it in my ear. Just put some glue in there.
All right, let's do that one.
Okay, I'm back. Oh, that's good. This is the best you've been. Okay. Mm-hmm. Yeah, I personally will check estradiol levels. I know our clinical assays probably don't have the sensitivity to really show that it's really all the way down, but I do like to see it go to undetectable on our clinical assays. I mean, that's kind of the best I can do, really. I think the younger the patient, the more you have to watch that, the more aggressive you have to be to really make sure they are shutting down. Because I think if you don't do that, in essence, you're risking them not having any therapy. Obviously, is what you're alluding to. Because if the AI restores ovarian function through the LHRH analog, then they're not getting any effective therapy. So I will generally check that. In younger patients, I will do the monthly regimens, and I'll check it. If patients get older, if they've had chemotherapy, I think they may be in menopause, I will give them the quarterly preparations and kind of look at 8 weeks because I've had a few patients that I thought would hold for a full 3 months, break through at 8 weeks. So I don't know, there's just no substitute that I've been able to come up with for checking. Yeah, I mean, basically what TAILOR-X did is it took a range of patients with a range of prognostic factors and randomized them to an intervention. MINDAC took a clinical risk profile, and randomized it against a genomic profile when there was discordance. So they were doing very, very different things. But a lot of the output from the MINDAC study, really because their primary endpoint was in that clinical high risk, low genomic risk group, that was their primary endpoint. There's been this question that we've had about, well, if we used their tools for assigning clinical risk and then looked at our data, could we improve the performance, in a sense, of the Oncotype DX recurrence score? And the short answer is, yeah, we think we did, as you said, in the intermediate risk group. What it shows basically, and it's a very simple risk system that you just basically the grade and the tumor size. You assign clinical high risk or low risk. And if in the women under 50 who have the intermediate range scores, particularly those who are 16 through 20 and 21 through 25, if you break those groups up into two subsets by their clinical risk, you see differential apparent benefits from chemotherapy. In the group 16 to 20, where when overall you see, well, maybe there's a absolute percentage point or two improvement, what you see is that when you split it into the two groups, the group who is a score of 16 to 20 and is low clinical risk does well. They have like a 95% distant recurrence-free interval. Chemo does nothing. If they have high risk, then there's actually about about an 6% delta between how they do with endocrine therapy. They have about an 89%. With chemo, it goes up to about 95%. So it looks like that group of 16 to 20 who has high clinical risk is benefiting from chemo. Again, with the caveat that is it the chemo or is it the ovarian suppression? And I think in the clinic, you have to have that discussion with the patient. We need to do chemotherapy. If you just don't want to do chemotherapy, then we really should do ovarian suppression, is kind of how I talk about it, particularly in that group. If you go up to that next group, where you have the higher scores, 21 to 25, you see there the women appear to benefit from chemotherapy irrespective of their clinical risk, though not surprisingly, the high-risk patients have about an 8% delta, and the low-risk patients have about a 6% delta. So for me, that's the same discussion with a patient. That's where we do want to take advantage of that. If we do it with chemo versus doing it with endocrine therapy and ovarian suppression, that's where the lengthy discussions have to take place. And again, I personally don't see how we're ever going to do a randomized study to answer that. I think we've got the data. We just have to individualize patient care with the information we have at this point. Yes, these are the correct. Yeah, everything I've said is in the women under 50, majority of whom were premenopausal. Yeah. Mm-hmm. Right. Yeah. I mean, there's always the caveat that in the studies, the percentage of patients that entered TAILORx who had high risk was only about 30%, and you got there with no negative disease. So it's a little bit. There is a point where as you get higher and higher, there's a little bit less certainty about it, but it's consistent. It's basically their risk is higher for recurrence, but they just don't benefit from chemotherapy, and that still remains the fundamentally that's the most important decision we have to make in our ER-positive early breast cancer patients. Mm-hmm. I'm sorry, you're speaking to the bone-directed? Yeah. I mean, the challenge that we've had in this whole area is that individual studies that were designed as indication studies were all negative. They did not show clear enough benefit that led to regulatory approval. When you do the meta-analysis, there's clearly seems to be benefit, particularly in postmenopausal women, from risk, having risk reduction for distant recurrence. It's not just skeletal recurrences; it's recurrences overall. So there is that overview evidence that I think warrants consideration of the drugs. For me, particularly when we use aromatase inhibitors, that their major long-term side effect is adverse effect on bone health. And so I guess maybe it's mentally lazy, but I just feel, what I tell my patients is, I know it helps your bones. We see that it reduces subsequent fractures. we're trying to cure you, give you a long life. I want to take care of your skeleton, and it's looking like it also may reduce your risk for breast cancer. So this is kind of where I am. I mean, I routinely employ bone-directed therapy. Now, what you use, that's where you'll get a lot of different opinions. So many people will just say, well, we can use oral bisphosphonates because the cost in getting the reimbursement, for the Zometa, for the denosumab is not insignificant, very clearly. So, I think for me the data is pretty clear that bone-directed therapy of some type should be done when you're doing endocrine therapy, particularly with aromatase inhibitors. I personally like the more, what I guess is somewhat more aggressive, the denosumab based on the ABCSG data. And we've not had trouble with reimbursements with our providers. Sure. Mm-hmm. Mm-hmm. Oh, yeah, we certainly do. Yeah. And that's why I say we will often send for an oncotype if we are considering neoadjuvant therapy to help us make a decision about are we ever going to do chemotherapy or are we going to do endocrine therapy? Because again, for me, I feel like in ER positive breast cancer, a major decision tool in our use of chemotherapy are these genomic assays. Ultimately, they become as important as clinical stage, as nodal status. And so I like as much information as I can to inform my decision. If I have a patient that is interested in breast-conserving therapy and she could benefit from reduction in her tumor, downstaging of her axillary nodes, I think that's a compelling reason to give her neoadjuvant chemotherapy. If I know I'm going to want to give it, why not give it pre-op? Why not get the benefits? Because some ER-positive women have a PCR and they do have a better prognosis. I think it's important information. If they've had the chemotherapy, if they've had a pathologic complete response, and they're really having a tough time on endocrine therapy, I'm a little less insistent about hanging in there if I know they've had a very strong PR. If I do surgery, I've lost that potential information. So I just feel like it's become such a useful tool for long-term management that and our group's kind of that way. We still will tend to operate, if the surgeon thinks that they can get the surgery done in a node-negative breast cancer that's ER positive, we generally operate on that. Where we have discussions are with the positive axillary nodes, the downstaging, that's the gray area. Yes, yeah, we have. If we get a favorable oncotype situation where there's no evidence at all that chemotherapy is going to do anything but give that person side effects, and they are interested in breast conserving therapy, but it's not going to be a cosmetically successful operation, we'll put them on and watch. And we don't really have a set duration. On a clinical trial, you have to have a duration to have consistency. But in practice, we'll if the tumor's getting smaller, the patient's tolerating it, we'll just keep going until the surgeon feels like they're ready to go. So, we've taken some patients out 9 months, 12 months, before we operate. Mm-hmm. Uh-huh. Mm-hmm. Sure. Uh-huh. Wow. Right. Yeah, CDK4/6 inhibitors have been really a breakthrough drug in our treatment of patients with metastatic HER2-positive breast cancer. It's interesting, the class of the research in this area was really developed thinking more in terms of higher grade hormone receptor negative disease because the CDK4/6 proteins are involved with cell cycle control. And so, when they are on, you have a very active cell in cycle. And so this was thought to be a very late common terminal point for multiple activating pathways. And if we inhibit that, we can maybe have an effect. The problem is, for that to work, your retinoblastoma gene has to be functional and intact, and it tends to be lost or have problems in those higher grade tumors. And where it actually is present in its functional state is most often the ER positive breast cancers, and those ER pathways converge on that same cell cycle pathway. So the combination of interruption of the ER pathway, whether you use fulvestrant, whether you use an aromatase inhibitor, you're trying to do the same thing, get less of a drive for the cycle to take place. If you then combine it with something that directly inhibits the cycle, there's been a marked potentiation of the activity of endocrine therapy by combining it with any one of the three drugs. And they actually do have single agent activity, though it's nowhere near what the combination is. Possible exception, abemaciclib seems to be quite active on its own, apparently more than the other two, but in combination, the data has really been quite remarkable for improvement in progression-free survival. The really exciting thing that's just come out at ASCO was that we're actually seeing improvement in survival in first-line metastatic ER-positive breast cancer, initially in the MONALEESA-7 in premenopausal women treated with ribociclib. That sort of brought up the question of, well, is this something about premenopausal patients? Is it ribociclib? But now we've heard Lilly has reported that their studies that are not with abemaciclib, that are in postmenopausal, are also showing survival advantage. So the drugs clearly have been a game changer in our patients with metastatic ER-positive breast cancer. Obviously, and the other nice thing about the medications is overall they have a pretty good toxicity profile. So you get a very effective drug that's reasonably well tolerated. You got to bring that up into the early breast cancer setting. And there have been studies that have finished accrual both with palbociclib and with abemaciclib, looking at adding the CDK4/6 inhibitors to higher risk breast cancers, ER-positive breast cancers that have completed accrual or in follow-up. I believe the ribociclib is gearing up to do a study now that there was the survival advantage that that they're trying to get that study done. So we're going to have lots of information on how they perform adjuvantly. Interesting thing is the initial pilots done for short exposures preoperatively, I think, were a little disappointing because they do show that you shut down proliferation. Now, this has been based largely on the Ki-67, which we've talked about not being completely reliable, but when you get, your lab says it's, in the 20s and it goes to 1, that movement's probably pretty reliable. But when you're on the drug, it will suppress. But by the time patients were getting to surgery and stopping the drug because it can suppress their white count, when you checked, the Ki-67 on the residual tumors had come back. So to me, that suggests probably short-term exposure is not going to be enough. It's probably going to primarily be an adjuvant setting, though this case would suggest if people are particularly sensitive, that may not always be the case. There weren't a lot of complete responses reported in those neoadjuvant studies, but since she had metastatic disease, how long had Matt had her on therapy? I bet it was more than 12 weeks. Oh yeah, and I was going to say another exciting thing about them is that the response rates are higher, the progression-free survival is double, and the thing you see clinically is those responses happen quickly. I mean, we now, before we had these drugs, if patients with liver mets, patients with any volume of lung mets, you kind of felt like you needed to get on top of it with chemotherapy. Most of us now will go to these drugs because they can work so quickly and they work for so long. So they really have been a game changer. So I think they're going to definitely have a role in early breast cancer. It's just, I think they're going to have to be around for a while to get an optimal benefit from them personally. But we'll see. The trials have different durations of therapy. The first one we're going to probably hear about is the Penelope study that GBG did with NSABP, which was post-neoadjuvant residual a la Catherine with really high tumor burden. That was a randomization to endocrine therapy or Palbo for a year. The adjuvant studies have gone 2 years, so there's going to be, sorting out the optimal duration like there always is. But my prediction is that there will be benefits to these drugs. I know they had their first interim that they passed. They didn't cross enough to report early, but so I think it might be 18 months or so before they get to the required number for analysis. Oh, I don't know. You got me on that one. No? Okay. Okay. Mhm. Well, I guess my assumption has been when you have a very effective first-line therapy that significantly reduces the tumor burden, you're just starting out with less evolved heterogeneity. It's a simpler disease, and when you have something that's effective across a broad array of tumor cells that doesn't select out the really highly resistant, fast-growing types, you can see these things happening. I mean, it's the same thing with Cleopatra. What's going on there? Why do you have survival advantage years after you stopped the pertuzumab and on multiple lines of therapy? What's going on there? It's interesting. And there's always right now the popular thing is the immune. There's engagement of the immune system, and there's been some studies that are suggesting that maybe part of what's happening is that there's a improved immune recognition or activity when you have CDK4/6 inhibitors. Who knows? Just glad to see it clinically. Sure, yeah. This was a 57-year-old woman who had a screening mammography and had a small 1.2 by 0.8 centimeter mass that was identified. A core biopsy showed a grade 1 infiltrating ductal carcinoma, very strong intensity staining for ER in 95% of cells. Always a little surprising to me when you see that in ER to see nothing in PR, but she was negative for PR, HER2 negative, and her Ki-67 was 5%. So she had and her nodes were negative on imaging. So we had basically a woman, healthy woman in her mid-50s who had this small, low clinical risk, strongly ER positive, low proliferating based on Ki-67 breast cancer, and she opted for breast-conserving therapy. And when we got all the tumor out, the pathologist still said, yes, it's grade 1. They didn't, sometimes you'll see the grade upstage, of course. It's always important to wait and see what the overall assessment is. But she did have the 1.4 millimeter focus of metastatic tumor in one of her lymph nodes. So we had talked with her, about being node positive and some of the different assays, and with her tumor being low grade like it was, low proliferation rate, I requested the Oncotype because I really thought that she'd come in low, middle range and all that stuff. I just think there's more, you get more information about the endocrine therapy, and the score kind of, I guess, came where you might expect for somebody who was PR negative. She came in at 20. So, she has a score of 20 with a low clinical risk. And so we discussed chemotherapy. She was postmenopausal, so anything she got out of chemotherapy had to come from the chemotherapy. There was not going to be ovarian suppression. And she ultimately decided that she would just go with the AI supported by denosumab, so that we have been treating her with that. We did find that I do like to get baseline bone densities. I check vitamin Ds routinely. She had osteopenia, had vitamin D deficiency, so we've been correcting those and have her on denosumab, and she's done well so far. Little bit of early morning joint stuff, but she's actually done quite well unusually so, frankly. Well, I mean, I guess the biggest thing that strikes me, and as you're taking care of patients, is really the variability of the problem. I mean, there are many patients that, most patients, if you question them, will say, well, maybe, but I find that up to a half of patients really just don't seem to have much problem with it, or they consider it minor, trivial. Patients who, but there are that 25% or so, 1 in 4 women, where it really does get to be a problem for them. And my first patient actually, she's a nurse, and she got to where she was having a very difficult time at work after she had been on maybe 18 months or so. I mean, it was really starting to impact her. And, she had that higher risk, she had the lobular features, and so what we ultimately did on her was actually, rather than going over to tamoxifen, because, there was the big 198 data that suggested that in lobular patients, the AIs were substantially better than tamoxifen, pretty large set of patients. I mean, nothing definitive, but I think that was a interesting exploratory analysis. We talked about that, and we decided what I do sometimes with these people is bridge them over to fulvestrant for a while if their risk is really elevated. If their risk isn't that elevated, I'll just say, let's take a break. If I generally will start with anastrozole or letrozole, so if they have problems, I'll talk about, let's try transitioning to exemestane, but I tend to take them off, give them a break, see if it resolves before starting a new medication. And I actually have a fair amount of luck with that strategy. I really have not, in terms of trying to treat it symptomatically, I'm not aware of anything that really is all that effective that patients want to take long term. And I tend to, and if there's problems, then I'll say, let's go, if they are lower risk, as I said, I'll say, let's do tamoxifen for a while. Because I think the critical thing is to make sure, do everything you can to help the woman stay on an effective endocrine therapy. And so I think you need to be flexible and work with them. Mm-hmm. Well, I mean, now it's with the data we have. You speak in a node positive patient, I guess, because the thing that really influenced on her was the grade 1. I mean, that's what, if this had been a grade 2 or a grade 3, I would have not, so that influences me, because I don't think any of the tests are perfect. They all provide information, and when they're all one way in concordance, I'm much more comfortable with more aggressive thinking. When I have things that are discordant, clearly my greatest concern is recurrence and death from recurrence. If there's discordance, I will tend to err on the side. A score of 20 in a postmenopausal woman who doesn't want chemo, that's still a pretty easy decision, but as you say, moving it up much at all, I'm starting to feel like I'm giving something up. But I have no problem with a woman with an intermediate score and 1 positive node saying, hey, that absolute 3 or 4% that I'll get from chemo isn't worth it to me. I'm fine with that. I mean, that's, to me, it's all about doing everything you can to accurately define their risk in a way they can understand without your drug, and then explain what we think the drug will do in an absolute sense, and then they decide if is that worth it to them or not. Oh, absolutely. Yeah, no. Right. Oh, absolutely. No, I mean I see no reason to get a test because a lot of times, or the really danger zone is where you and the patient have made a decision and you sort of say, well, let's get that and it'll reinforce us. If that seems like that's when you're going to get the surprise and going the other way. So it really is, I think it's important for them to understand that, it only is worth doing this, in my opinion, if we get something, we will act on it. Because otherwise, we're just giving you something to worry about and more uncertainty. Right now, I guess just I can't recall having a genomic assay on patients with more than 3 positive nodes. I think if the decision can be made without that, because if you're not giving chemotherapy, you're having somebody who has comorbidity where you're really worrying about the value of it at all, or they really are just not wanting it. So it gets into what we were talking about, where will it make a difference? So it's something that I primarily will do with my grade 1, grade 2 tumors who have 1, maybe 2 lymph nodes. I can't remember one with 3, but I probably, would still think about it in that situation. Yeah, I mean the one prospective data set that led to getting the MammaPrint on NCCN guidelines and so forth was the MINDAX study, where they did include node positive patients as high risk patients 1 to 3 nodes. I mean it is important to acknowledge it started out as a node negative study. The patients with node positive were added later, and they never really break out that high risk group that I've been able to find, in terms of forest plotting the node positives from the node negatives. But there's really no reason to believe that there would be a big difference. But they did show that in patients who had the high clinical risk, which would have included the node positive patients, higher grade tumors, who had a low score, they did quite well at 5 years. Their 5-year distant recurrence-free interval was about 95%. And so it met their criteria for saying that's enough to feel comfortable omitting chemotherapy in these patients, and so it was approved on that basis. We don't have that yet, that type of data yet with TAILORx, because the decision was made to study the Oncotype score in responder, similar to what was done in TAILORx, though the recurrence score ranges were changed appropriately. But there has been a substantial uptake of the Oncotype, even in node-positive patients, sufficient that GHI was able to work with the SEER database, looking at how patients did according to their recurrence score, out to 5 years with positive nodes, and that data set was on the old range, before the shift, but it's all consistent with the fact that the low recurrence score patients do well with endocrine therapy alone with 1 to 3 positive nodes. you didn't have the real clean data. All you knew is that, the lower recurrence scores with 1 to 3 positive nodes, the majority of the docs didn't give chemo. And those patients did well. A small percentage did. So it's not clean data, but it's supported data. So for me, again, because I value the Oncotype DX recurrence score so much for managing my endocrine therapy, that's the assay that I prefer, even with the node-positive patients, recognizing that we don't yet have the randomized data, that I am relying on retrospective data from SEER. There was also data from a large study, providers, health insurance coverage in Israel that, same sort of thing, where Israel standardized their use of Oncotype very, very quickly, so they were able to publish some retrospective data as well. It's all consistent. Oh, I think it was. I mean, I think it was the Catherine results were remarkably robust in terms of the magnitude of the benefit, but also the breadth of the benefit. Because one of the challenges we had going into Catherine is we knew identifying patients with residual disease, we were going to have a lot of heterogeneity. And so there was a question about, how many patients do we need? What type of patients are going to come into the study, so we can see a signal and be sure that if there is a group benefit, we don't miss them. These are the sort of things that you work with design of the trial. And the remarkable thing was that the hazard rate was 0.5, but it was there across all of those subsets. So really a remarkable benefit, I think, from the therapy. And I think it is a practice-changing study, and that the data, I think, challenges us to really think about what would be the role of surgery first, followed by adjuvant therapy, when we have such compelling information that patients can receive very effective frontline standard therapies. Many of them have a PCR. We know that overall they do well, and the subset that clearly don't do as well. Now with TDM1, their outlook is really very similar to the outlook of the women who PCR. So you really now, when you sit down with a HER2-positive breast cancer patient, you can really be very optimistic with her that we have a process to go through. We're going to treat you with our best drugs. If they work, great. Then we finish out a year of antibodies. If they didn't quite get us where we wanted to, then we make a change that will get you to about where you would have been had you PCR. And I think that's very exciting information to be able to share with patients now. Mm-hmm. Mm-hmm. Right. Yeah, I mean, Catherine was basically a study that was targeting women whose initial biopsy was HER2 positive, who received one of the global standard regimens. We just, we tried to be pretty loose with that because we knew we'd have to do this study globally. Didn't require an anthracycline, but allowed an anthracycline. Didn't require two antibodies, but allowed an antibodies, and only 20% of patients got two antibodies, largely from the U.S. accrual. So we had a lot of flexibility in terms of the design, and we decided that we would allow patients in the study with any amount of residual disease. That was a design issue early on. Fraser Simmons, work with RCB had certainly suggested the 0 to 1s when you look at all breast cancers. The RCB1s do as well as the PCRs, so would they have enough events? Is it worth the potential toxicities? Because when we launched Catherine, there was still some uncertainty about hepatotoxicity. So we were taking it from metastatic into early settings, so there were, these were things that we had to think about. But we basically tried to make it as broadly inclusive as we can, and we had pretty involved stratification factors, how they presented, inoperable versus operable, ER positive, ER negative, single versus dual HER2, and then finally, at surgery, did they have residual nodal disease? We thought those were the important things to get right. And when you look at the data, those were good things to pick because you do see that patients with inoperable disease, patients with ER negative, patient with residual nodes have a higher event rate than their counterparts. But everybody, irrespective of how they did with trastuzumab, had this 50% reduction in their risk. So the inoperable patients who came in inoperable and when converted to operability, but still had lots of residual disease, they still had a pretty high event rate, but that was cut in half with TDM1. It went all the way through. Even the subset of patients who had less than a centimeter residual tumor and negative lymph nodes, they did much better with trastuzumab. They had an 85% disease-free interval there when we were looking at it. That went up to 90 with the TDM1. So everybody benefited from the therapy, which was very gratifying. So that was basically what it was. The study was set up so that, and this was an interim reporting boundary. We sized the study looking for about a hazard of 0.73. We thought a 25% reduction would be clinically meaningful. But we built in the interim, and it crossed because it was so much bigger than what we had thought. But as part of that, since we knew we were going to be taking it to the regulators and they would want to know about survival, it was planned to do a survival analysis. But there's so few events in both arms, there's no difference. The trend is in the right direction, but you can't make any comments about that. So we still will need to follow these patients to understand the full magnitude of the benefit over time. But as we know in HER2 positive, that can take years now because patients do so well. Mm-hmm. Sure, yeah, the immunoconjugates are very exciting for medical oncology because I think in a sense they really are realizing the ultimate promise of the monoclonal antibodies. When the monoclonal antibodies were first developed, there was a recognition that these drugs might be a way to selectively deliver toxic payloads to cells that are making the target, but it took a long time to take that straightforward concept into reality. It's not easy figuring out the right linkers, getting the right targets and things of that type. And so, but now that the companies that work through this, we really are seeing that these drugs are quite effective with substantially reduced toxicity. They are chemotherapy. You still see chemotherapy like toxicities with TDM1. You can see hepatotoxicity, thrombocytopenia, but the intensity of it, the frequency of it, markedly reduced, so patients are able to take the therapy. In TDM1, the chemotherapy drug targets the mitotic spindle, and drugs that target the mitotic spindle tend to cause neuropathy, so that's a potentially problematic side effect that oncologists have to pay attention to, and sometimes will require early discontinuation of the drug, particularly when you administer it sequentially after they had initial taxane-based therapy. We do have information on TDM1 as neoadjuvant therapy from the Christine study, and you see really very little neuropathy in that study. So there, relative to what we were seeing in ours. So there is, it's not all TDM1, it's TDM1 following the initial taxane. But they basically, the idea of the immunoconjugate is you load it up with chemotherapy drug, on the monoclonal antibody, then the FAB portion binds to its target, it's internalized, and then the chemo is released internally, so you get the cancer drug to the cancer cells and hopefully spare the normal tissue. Of course, it's not perfect. Some of the chemotherapy dissociates before it gets into cells, so this is why you do have side effects, but this is part of the amazing art and science, I think, that the companies that are working on these, because they keep improving them as they, not surprisingly, there are companies now that there are new compounds being developed that carry more molecules per antibody. With TDM1, it's about 3. Some of the newer ones have 6 to 8. They use different chemotherapeutic drugs, things that target topo1 that don't have overlap with taxane. So that, I think there's a lot of excitement about these drugs potentially in HER2 positive as competitors for TDM1, but we also have a number of agents in the triple negative space that are showing promise as well. Oh yeah, I was actually, it was, the IDMC looked at the interim data on Friday afternoon, and I knew that they would be letting Norm Walmart know about it as chair for NSABP Foundation, and I was in finishing up notes from the previous week in clinic, and I thought, I should be hearing something from Norman by now, but he didn't say. I emailed him and I said, so I haven't heard anything, so I guess we didn't cross. And he texted back, oh, we crossed big time. It was like, you gotta be kidding. It's just amazing. Because I didn't, personally, frankly, I did not expect to cross early. I really didn't. I mean, I was amazed when I saw, because then of course I said, well, how much, what was the hazard rate? Can you share that? And he finally told me what that was. It's just amazing. And then as you see the data set, see the consistency, it's just really, really fun. It was a lot of fun then to show it to other, thought leaders and such, and hear the reaction and stuff. Very gratifying. Right. Mm-hmm. 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 Yes, and I assume on biopsy, repeat biopsy, it is HER2 positive, it's triple positive, it's the same thing back. And metastatic workup isn't showing anything, but she's got a locally advanced kind of inflammatoid relapse, is what I'm hearing, right? I get that right? Okay. Okay, yeah, okay. Well, in this case, I would go back and give her things that I didn't give her the first time, in a sense. I would probably, assuming she's not having any residual neuropathy, if she didn't, I would go back and see what I could get out of my THP, the thing I gave her before, see what it would do. I would like to know that in terms of activity. I would plan on, I would think I probably could only give her maybe 8 to 10 doses of paclitaxel before she's going to start getting neuropathy. This is the sort of person that I might find out if I could possibly get nab-paclitaxel just to see, but I would not, if I could, I would go to nab-paclitaxel to give her a different taxane preparation, maybe less neuropathy, but if it wouldn't get approved, I'd go ahead and do the Taxol, but I'd watch her very carefully, planning to then sequence to, and assuming she's responding, then I would sequence to AC, again, assuming her heart's fine, of course, and then I would hope at that point I would be ready to operate and see what I have, and then I would expect I'm going to have residual disease, and frankly, even if I didn't, I'd probably go ahead and give her TDM1. I think a question I get that's not entirely, you hear from Catherine is, well, gee, how do you know that the patients who had PCR might not have had some risk reduction had they taken it? Are you sure PCR says no? And the honest answer is, well, no, I'm not sure about that. We only studied non-PCR. There is room for improvement in PCR patients. GBG showed their data that when you have positive nodes at presentation, when you start out with T3, T4 tumors, even with PCR, you do have higher risk for recurrence. So even if she did get to a PCR in this situation, since it's her second time through, I would go with TDM1 based on the Catherine data. I would always be looking at my residual disease to guide my endocrine therapy. Ultimately, and I think the obvious thing with triple positives is, what about CDK4/6 inhibitors because of that. The Alliance is doing a phase 3 study looking at that in patients with metastatic disease. She doesn't have metastatic, but it's recurrent, locally advanced. Those patients, she undoubtedly has occult metastatic disease, even if her scans aren't showing it. So she's one that I think there's so many options, but I do think it makes sense to be aggressive and treat her with curative intent in this situation. Not think in terms of palliation, because I assume she had radiation, so she probably won't be able to undergo radiation again. So you're really needing to get as much as you possibly can out of your systemic therapies. And I would be pretty intense about it because I do think there's a chance that you could get a durable control of the disease, quote, cure still, particularly since he didn't stick with pertuzumab. I'd definitely go back to the pertuzumab. Mm-hmm. Mm-hmm. I've heard theories about it. No, I mean, my assumption has been that these patients, for the most part, most of them, their residual disease is still HER2 positive, and the immunoconjugate is simply delivering a higher dose to those cells. The real, the interesting question that, that I've heard some people talk about is, well, maybe what's happening is it's dormancy and cells are coming back, or when you take away the trastuzumab, pertuzumab, HER2 expression is coming back stronger and the drug is getting in. We don't know. I think the drug, that 50% tells us that something is going on more than what it just can't simply be that the immunoconjugate's working that well. It's got to be something's going on about that prior exposure to taxanes that definitely cytoreduce these. Because most patients get substantial cytoreduction. It's just, does it all go away, yes or no? And then we're withdrawing that therapy and coming in with something else. There's something going on there, because that's, a lot of people say, well, maybe we can flip them. And I think that's a question, but I would be careful about that. Particularly with the Marianne data. But we see in Christine that if you get TDM1 as neoadjuvant therapy and you have a PCR, you do very well. So the question is, if you don't, then are you as salvageable with HPAC, whatever you use, as you are with TDM1? That would have to be a clinical trial done to sort all that out. And is that the reason to do it would be the perspective that, well, it's better to limit my exposure to my more toxic chemo to the half that need it. And it'll be fun to see if that study can come to fruition, but it's an obvious question that's going to come up after the Christine data. The other thing we've got to sort out in HER2 positive, of course, is there are subtypes of HER2 positive, clearly. And we all know they're there. A problem we've had with developing HER2 targeted therapy is that the presence of HER2 made trastuzumab worked in everybody. I think as you go beyond that, we're starting to see the different tumor types respond differently to additional therapies, and that's where I think we're going to have to get smarter about the subtypes of the HER2 positive breast cancers, particularly as we're trying to de-escalate and do these things. All right, thanks, Neil. All right, you too. Bye-bye. Oh, sorry about the squeaking. I'm glad you gave me the sign. I wasn't it's so hard to hear. It's just like, eh. And last time I did this with him, it was like, what, eh? And it seems to be on their end. All right. Thanks so much. Boy, that went over, didn't it?
What you did?
Okay. Put my car still out there.
Oh, thank you.
Have a good day.
All right. Hey, yeah, just finished. Well, when you first cut, I think your computer might have timed out. As soon as you touched it, it came back on. And then you started changing things in the background. No, it just went, you went into sleep mode. You didn't have it on, you must have had it on an hour before it's, there's a client I gotta tell them about it. They don't know what happened. It wasn't live. It was just, I'm recording with cameras. They don't know that this background is here. So let me talk to them. They're calling me now. Hang on. Hello. Hello. I think everything went pretty good except for one thing. There was a brief period where apparently the computer went into sleep mode for the background. So we lost the background for the. Is that something you can edit? This is being edited, right? I mean, is there any, well, it's like the bookcase thing. Um, it went to kind of a, well, it's like a purple looking screen because it says HDMI signal lost. So I guess it didn't have a long enough sleep time on the, I guess it had a sleep period in there, didn't realize it. And it went into sleep, and by the time I got it back up, it had been about a minute or so. So, yeah. Okay, all right, we'll do that. What I'll do, you know what I'll do? Why don't I'll shoot video of it, so you have the video. I'll just roll for a couple minutes on the video. Then you'll have it. All right. I'm roll now for about 2 minutes. He was moving a lot. Kept pulling his earpiece